Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. You can easily download them, view them at your convenience. We also have a Telegram group, which is where you can join, where all the lecture related information is available. We also have a Google Drive where the PDF of all lectures are available. And we have a master integration key which helps you navigating between the Google Drive as well as the YouTube. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have Pursue 26S, which is Dermatopathology, and we are streaming from AIIMS, Bhubaneswar, India. And the topic of the day is Genodermatoses. To talk on that, we have Dr. Madhusmita Sethy. She's an MD Pathology. Presently, she's an additional professor in the Department of Pathology and Lab Medicine, AIIMS, Bhubaneswar. Her areas of interest being dermatopathology, cytopathology, and surgical pathology. She's got multiple publications in international and national journals. With this, let me request Dr. Madhusmita Sethy, ma'am, please start your lecture on genodermatosis. Thank you so much. All yours.
Greetings everyone. Today we will be discussing about genodermatosis or congenital diseases of the skin. Genodermatoses are a group of inherited diseases affecting the structure and function of skin, nails, and hair with or without involvement of other organs. There are various conditions enlisted in this group, and I will be discussing some common variants or the conditions which show characteristic dermal findings. The first condition we are going to discuss is ichthyosis. This is the most common type of genodermatosis in which the skin becomes scaly. The word ichthyosis is coined from the Greek word ichthys, meaning fish. There are 4 major and 3 minor variants of ichthyosis. Those are being tabulated here. We will be discussing one by one. Beside those major and minor variants, the skin lesions of ichthyosis can be seen in many syndromes. A few of them are listed here. Ichthyosis vulgaris is a major variant of ichthyosis which is transmitted in an autosomal dominant pattern. A mutation in the filaggrin gene gives rise to this disease. It develops few months after birth. The patient develops scales on skin which are large and adherent to the extensor surface of the extremities. Other body parts may show fine and small scales. The flexural creases are spared. Keratosis pilaris is commonly seen in this condition. Hyperkeratosis is seen in palm and soles. An acquired form of this disease is seen in sarcoidosis and malignancies like Hodgkin's disease. In histosection, the skin shows mild to moderate amount of hyperkeratosis with loss of basket wave pattern and follicular plugging. The granular layer is absent. The dermis appears normal. So what is the pathogenesis of this condition? Normally, what happens? The keratohyalin granules present in the stratum granulosum layer of the skin contains a protein known as filaggrin. These filaggrin proteins are derived from a precursor protein known as profilaggrin, and one profilaggrin protein can give rise to 10 to 12 number of profilaggrin by proteolysis. And these filaggrin molecules are attached to the keratin filaments. On exposure to external humidity, these filaggrin proteins are further degraded to form NMF, means natural moisturizing factor. But what happens in ichthyosis? In ichthyosis, there is reduced expression of profilaggrin and abnormal expression of these keratohyalin granules, which are small and spongy in appearance. And this is the reason for the dry and scaly skin of this condition. The epidermal proliferation in this condition remains normal. So the hyperkeratosis seen here is retention type. The next variant is X-linked ichthyosis. Gene deletion is seen in 90% of these conditions. This is rarely present at birth. As this is a X-linked recessive condition, males show the severe form of this disease. Flexural creases may be involved, and the thickness of the scales increases with age. Normal desquamation process is carried out by the enzyme steroid sulfatase, which degrades cholesterol sulfate at the upper layers of the stratum corneum. Cholesterol sulfate acts as a cohesive element in the lower stratum corneum. This cholesterol sulfate is present in the Odland bodies found in stratum granulosum layer. These Odland bodies in electron microscopy shows lamellation as shown by the green arrows. So for this feature, these Odland bodies are also known as lamellar bodies. In this X-linked ichthyosis, deletion of this steroid sulfatase gene causes retention hyperkeratosis. Another variant of ichthyosis is epidermolytic hyperkeratosis. This is also known as bullous congenital ichthyosiform erythroderma. This is an autosomal dominant condition. The patient presented with generalized erythema at birth. Gradually, thick verrucous scales are developed. Flexural surfaces of these extremities are involved in this condition. Features like vesicle, bulla, and erosions are encountered only during the first few years of life. Two characteristic microscopy features are noted in this condition. One, epidermolytic hyperkeratosis, and second one is granular degeneration. The upper part of the stratum spinosum and stratum granulosum layers are mainly involved. Hypergranulosis and compact hyperkeratosis are commonly seen in this condition. The granular layer keratinocytes show perinuclear halos or clear spaces, and the cell boundaries in this layer are formed by a faint thin line of granules. So these clear spaces along with edema forms intraepidermal bulla. Mitotic figures are greatly increased in comparison to the normal epidermis. Moderate amount of chronic inflammation is usually seen in the upper dermis. The genes involved in epidermolytic hyperkeratosis are keratin 1 and 10. The hyperkeratosis is due to excessive and abnormal keratinization with excessive production of tonofilaments and keratohyalin granules. These keratohyalin granules produced are premature. Desmosomes are normal, but the association between desmosome and tonofilament is abnormal. Due to excess production of tonofilaments, one desmosome gets attached to 2, 3 or more number of tonofilaments, and that causes epidermolysis. The characteristic microscopic pictures seen in epidermolytic hyperkeratosis are not specific for this condition. Similar features can be seen in epidermolytic keratosis Palmaris et Plantaris, in solitary or disseminated epidermolytic acanthoma, and in linear epidermal nevus. So, clinical correlation is very important. Autosomal recessive ichthyosis are two types. One is congenital ichthyosiform erythroderma and another one is lamellar ichthyosis. Congenital ichthyosiform erythroderma is less severe variety and clinically presented as fine scales and pronounced erythroderma, while lamellar ichthyosis is more severe kind and presented with large scales with and severe ectropion but mild erythroderma. Flexural surfaces, palm and soles are involved in both types. Mutation in TGM1 is the cause of this disease. In microscopy, congenital ichthyosiform erythroderma shows mild hyperkeratosis with foci of parakeratosis, but in lamellar ichthyosis, the microsection shows marked hyperkeratosis without any parakeratosis. Here, child syndrome is worthy of discussion, which is expressed as unilateral ichthyosiform erythroderma and ipsilateral underdeveloped limbs. Child stands for congenital hemidysplasia with ichthyosiform erythroderma and limb defects. This disease is thought to be X-linked recessive disorder because all reported cases to date are females. The fibroblast of the skin of affected patients shows paroxysmal abnormalities. In histosection, both hyperkeratosis and parakeratosis are seen. Harlequin ichthyosis is categorized as a minor variant of ichthyosis. A harlequin is a clown character always dressed with a checkered pattern, and the affected baby at birth is covered with a thick horny cuticle, giving a similar appearance. In histosection, the skin shows massive hyperkeratosis. The presence of granular layer is variable, but with fat stain, small droplets of neutral fats uniformly distributed in conified cells are seen. Here, mutation in ABCA12 gene causes formation of abnormal lamellar bodies. The next minor variant of ichthyosis is Erythrokeratodermia variabilis. This is an autosomal dominant condition, develops in infancy. The babies show two main clinical findings. One is erythema which expands centrifugally and coalesces to form succinate figures with its apex at the center like this leaf of the fawn. And these are the erythematous patches. And this feature is very unstable. That's why the name variabilis. The second feature is persistent hyperkeratotic patch. The microscopic picture in this condition are very non-specific, but the granular layer remains normal. The hyperkeratosis seen in this condition are retention type, and the defect lies in the connexin 31. The third type of minor variant of ichthyosis is known as Ichthyosis linearis circumflexa. This is an autosomal recessive disorder. This is clinically expressed as extensive migratory polycyclic lesions of erythema and scaling. The skin scales seen here are very characteristic, showing double edges. When this skin condition is associated with Netherton syndrome, one abnormality of hair is very commonly seen, which is known as trichorexis invaginata. In this, the distal part of the hair, which is very firm, gets wrapped by the abnormal proximal part of the hair, and this wrapping creates an illusion of as if the distal parts gets invaginated into the proximal part. Refsum syndrome is an autosomal recessive disorder which is expressed as generalized ichthyosis along with cerebellar ataxia, progressive paresis of limbs, and retinitis pigmentosa. This condition happens due to mutation in phytanol-CoA hydroxylase gene, which leads to accumulation of phytanic acids. So, in microscopy, lipid vacuoles of different size are seen in the cytoplasm of basal and suprabasal cells of epidermis. The next congenital skin condition we are going to discuss is Keratosis Palmaris et Plantaris. 3 autosomal dominant and 2 autosomal recessive variants of these conditions tabulated here are known to exist. As the name indicates, the skin of the palm and sole gets conified. This is also associated with many syndromes like Pachyonychia congenita, and hydrotic ectodermal dysplasia. The microscopic findings are non-specific, but in epidermolytic keratosis palmaris et plantaris variant, microsection shows intraepidermal blister formation, cytoplasmic vacuolation, and large and increased amount of keratohyalin granules, as seen in the epidermolytic hyperkeratosis, one variant of ichthyosis. Multiple abnormalities involving structural protein, gap junction protein, and enzymes have been noted in this condition. In Acrokeratosis, multiple small shiny papules are seen along the peripheral border of the palm and sole. This is an autosomal dominant condition. In microsection, the skin shows decrease and fragmentation of elastic fibers in the deep dermis. These are the pictures of dyskeratosis congenita. This is the disease characterized by a triad of clinical findings, including dystrophy of the nail, where the nail plate is not formed at all, leukokeratosis of mucosal membrane, as seen in these white patches in the oral mucosa, and anal mucosa is also involved. Net-like pigmentation, here you can see the pigmentation of the skin, and in microscopy the findings are very non-specific, but in hyperpigmented areas, presence of melanophages is a constant feature. Now we will discuss about porokeratosis or porokeratosis of mibelli. This is an autosomal dominant condition. It shows variable clinical manifestation. Clinically, there are 5 types. One is plaque type, which is classically described by mibelli. Second one is disseminated superficial actinic porokeratosis, which is commonest variant, and the lesions appear on sun-exposed body parts. The third one is linear porokeratosis, usually shows segmental involvement. Porokeratosis plantaris palmaris et disseminata. The lesion starts from sole and palms and extends to other parts. And the fifth one is punctate porokeratosis. Here, seed-like lesions are seen. The lesions of disseminated superficial actinic porokeratosis and linear porokeratosis can develop into squamous cell carcinoma. Ideally, the skin punch biopsy should be taken from the peripheral raised hyperkeratotic ridge of the lesion, where the characteristic finding of formation of corner lamella is seen. Corner lamella is a stack of parakeratosis invaginating downwards into the epidermis at an angle with the apex away from the center of the lesion. Here is the microscopic picture in low power view showing hyperkeratosis and acanthosis with papillomatosis. In higher power view, you can see the stacks of parakeratosis. So multiple foci of this type of corner lamella formation are seen. In deeper section, it shows the formation of proper corner lamella, which is the stack of parakeratosis invaginating into the epidermis. And the keratinocytes in the corner lamella shows pycnotic nuclei. In hyper view, you can see the formation of corner lamella and the abnormal keratinocytes beneath it. So it is seen that a clone of abnormal keratinocytes are present beneath this cornered lamella. The similar type of stacks of parakeratosis can be seen in verruca vulgaris, solar keratosis, or in plantar or palmar wart. Xeroderma Pigmentosum is an autosomal recessive condition, usually affects sun-exposed areas of the body. This condition clinically follows three stages. First is freckles. Second is this lesional skin gets atrophied at places with development of mottled pigmentation and telangiectasia. In third stage, features of malignancy are developed. Normally, squamous cell carcinoma and BCC are developed in the lesions of Xeroderma Pigmentosum. In de-Sanctis-Cacciano syndrome, Xeroderma Pigmentosum is associated with neurologic manifestations. The microscopic picture in first stage are very non-specific. It shows thinning of stratum malpighi, hyperkeratosis, irregular ridges, irregular accumulation of melanin pigments in the basal layer. In second stage, the previous hyperkeratosis and hyperpigmentation gets accentuated. Atrophy and acanthosis of variable degree is seen in the epidermis, and solar elastosis is present. In third stage, features of malignancy develops, which is squamous cell carcinoma or BCC. Here, the defect lies in the excision repair, which is brought by DNA endonuclease. But in some variants, there is defect in post-replication repair. These are known as XP variants. Giant melanosomes and pleomorphic keratinocytes are also seen in Xeroderma pigmentosum. Abnormalities of hair, nails, teeth, and sweat glands are seen in ectodermal dysplasia. There are two types of ectodermal dysplasia. First one is hydrotic variant. This is autosomal dominant condition. Hypotrichosis, dystrophic nail, palmoplantar hyperkeratosis, and dental hypoplasia-like features are seen in this condition. Variable degree of alopecia may be seen. The second variant is hypohydrotic, which is X-linked recessive variant. This is clinically presented with tetrad of findings comprising anhidrosis or hypohidrosis, hypotrichosis, dental hypoplasia, characteristic facies. The baby is presented with a broad nasal bridge, frontal bossing, and wide and patulous lips. There is intolerance to heat due to reduced sweating. Abnormal dentition is seen. The teeth of the baby becomes peg-like. In microscopy, hypoplasia of hair and sebaceous glands is seen in both hydrotic and hypohydrotic variant. In hypohydrotic variant, the eccrine glands are absent or very few present in mainly in palm and axilla. If they are present, they are very poorly developed. They mostly resemble endothelial cells. The excretory ducts seen in hypohydrotic variants are lined by single layer of epithelial cells. So now the next condition is epidermolysis bullosa or EB. This condition is classified according to the plane of bulla formation as epidermal, junctional, or dermal. So here the classification of EB with their inheritance pattern and clinical findings are tabulated here. Here you can notice that oral involvement is seen in almost all variants except in EB cocaine. So skin punch biopsy is necessary for the diagnosis. Biopsy is usually taken from the fresh blisters or induced blisters to avoid secondary changes. The blister plane in microscopy can vary according to the age of the blister due to epithelial regeneration. For biopsy, blister can be induced with a gentle friction by a cotton swab. PAS special stain can help to distinguish different type of EB. In epidermal variants, PAS positive basement membrane zone located in the dermal side of the blister. And in junctional variants, the PS positive basement membrane zone will remain with the dermis. In junctional variants, the epithelium of GI tract, respiratory tract, and urinary tract are also affected. In dermal variant, PS positive basement membrane zone is very hazy and difficult to notice. If it is present, it remains towards the epidermal side and it is splitted. So these are the pictures of junctional EB showing loss of epidermis, and this is the picture of dystrophic recessive variant of EB, which shows generalized lesions and mitten hand deformity. Scar is also developed on these lesions. And this is the microscopic picture of junctional EB showing subepidermal bulla formation. Epidermolysis bullosa acquisita is an autoimmune condition develops in childhood or adult life, shows blister formation at the traumatic site, which gives rise to atrophic scar formation, and oral lesions can also be occasionally seen. Circulating IgG antibodies are detected in patient. This is the picture of EBA. The lesions of hand, which gives rise to the scar formation, and tiny milia marked as yellow cross are seen on the scar. In microscopy, subepidermal bulla formation is seen, but this condition can be differentiated from bullous pemphigoid or EB by direct immunofluorescence test or by salt split skin DIF. Hailey-Hailey disease or familial benign pemphigus is an autosomal dominant condition which shows defect in ATP-dependent calcium transport. Clinically, this condition is presented as localized recurrent eruptions of small vesicle on an erythematous base. Intertriginous areas like axilla and groins are mostly involved. In histosections, supravasal acantholysis involving a large portion of epidermis is seen, which gives a dilapidated brick wall appearance in microscopy. Diskeratosis is minimal or absent. Another autosomal dominant condition is Darier's disease, which is also known as Keratosis follicularis, because in this condition, crusted papillary eruptions are seen mainly in follicular distribution. The clinical lesions may be hypertrophic, vesiculous, or linear or justeriform tracts. Similar clinical manifestations are seen in Acrokeratosis verruciformis of Hopf, which are seen in the first picture, the lesions of the hand. The second one is Darier's disease, and the third one is leg lesions representing acantholytic dyskeratotic epidermal nevus. The clinical findings resembles with each other. So the lesions of Darier's disease mainly show acanthosis, papillomatosis, and hyperkeratosis. This is the microscopic picture of Darier's disease in low power view. In this disease, dyskeratosis is very characteristic and very prominent in the form of coughs, runs, and grains formation. In high power view, you can see there is supravasal acantholysis with dyskeratosis. There is villi formation which are lined by single layer of basal cell. So this is the picture showing Cough's runs and grains. Cough's runs are dyskeratotic keratinocytes which are round in shape with pycnotic nuclei, but grains are the flattened cells or flattened keratinocytes. Here, a comparative microscopy pictures are seen with Acrokeratosis verruciformis of Hopf and acantholytic dyskeratosis epidermal nevus with Darier's disease. The features of various disease we just discussed. In Acrokeratosis verruciformis of Hopf, we will see hyperkeratosis, hypergranulosis, acanthosis, and papillomatosis. In acantholytic dyskeratotic epidermal nevus, though features of dyskeratosis is seen, the hyperkeratosis and acantholysis are also seen, but the formation of coughs and rounds are very rare. Acrokeratosis verruciformis of Hopf is an autosomal condition which shows verrucous hyperkeratotic papules in distal parts of the extremities, as seen in this picture. Microscopy picture we already discussed, where we will see marked hyperkeratosis, acanthosis, and hypergranulosis. Sometimes papillomatosis with church spire-like elevations of the skin is seen. Pseudoxanthoma elasticum, as the name indicates, some defect in elastic fiber is seen. There are two autosomal recessive and two dominant variants are present. The classical type is the recessive type 1 and the recessive type 2 is very rare, but it shows only cutaneous manifestation, which are extensive. The lesions are xanthoma-like, like soft and yellowish papules with wrinkled skin, which appears in second or third decade of life and progressive in nature. The sides of the neck, axilla and groin are mainly involved. In eye, angiostreaks of the fundi leads to blindness. In GI hemorrhage is the common feature. If coronary artery is involved, repeated attacks of angina pectoris is seen. And if peripheral large arteries are involved, it manifests as claudication. Skin punch biopsy of this condition shows accumulation of swollen and irregularly clumped elastic fibers in the middle and lower dermis. The elastic fibers are also calcified. So this is the low power view of the skin of this lesion, which consists of epidermis and dermis, and we can see these clumped elastic fibers in the mid dermis and in the deep dermis. In the high power view, we can see clearly these clumped elastic fibers. These elastic fibers stain positive with VVG stain and also stains positive with von Kosa, as these are calcified. Connective tissue nevus is a hematoma with increased collagen with normal, decreased or increased elastic fibers. Clinically, they are slightly elevated and indurated nodules grouped together or widely disseminated. They are present without involvement of other organs or may present as autosomal dominant variant with osteopoikilosis, as seen in Bosque-Ollendorff syndrome. This is the clinical picture of connective tissue nevus. These are the skin nodules. And in microscopy, this is very difficult to diagnose. If it is compared with the normal skin, we will see increased amount of collagen in the dermis. Cutis laxa or elastolysis, which is also known as dermatopathology or generalized elastolysis. In this condition, the baby is presented with a loose skin. The skin can be easily pinched off. And in microscopy, there is decreased density and fragmentation of elastic fibers. The abnormalities lies in the microfibrils and elastin. Urticaria pigmentosa or mastocytosis, sometimes inherited as autosomal dominant condition with mutation in KIT gene. There are 4 forms of this disease: infancy or early childhood without systemic lesions, adult life without systemic involvement, systemic mast cell disease, or mast cell leukemia. Clinically, the patient presented with flushing, palpitation, and diarrhea due to release of mast cell granules. 5 types of cutaneous lesions are seen in Urticaria pigmentosa. These are maculopapular type, multiple brown nodules or plaques, solitary large cutaneous nodules, diffuse erythrodermic type, mastocytosis, telangiectasia, macularis eruptiva perstans, which is seen in adults. In multiple nodules or solitary nodule variant and diffuse erythrodermic type, bullous lesions are commonly seen. In microscopy, infiltration of mast cells are seen. Few eosinophilic infiltration is also present. Sometimes subepidermal bulla formation can be seen. The basal layer is hyperpigmented due to stimulation of melanocytes by mast cells. Few melanophages in the superficial dermis is usually marked. This is the microscopy picture showing infiltration of mast cells which are marked by the metachromatic granules in the cytoplasm. This is the high power view, and these mast cells can be detected by special stent, the toluidine blue. Toluidine blue stains them the cytoplasmic granules. In maculopapular type and telangiectasia macularis eruptiva perstans type, the infiltration of mast cells are only in superficial dermis and surrounding capillaries, and these are very sparse in these conditions. So, in these two type of mastocytosis, we have to take help of special stains to highlight the infiltration of mast cells. Incontinentia of Pigmenti is a X-linked dominant condition, but this is not a very severe condition. So, male patients with genetic mosaicism or compensatory X chromosome, as in Klinefelter syndrome, can be seen with this disease. Familial form is the classical form which involves IP2 gene. Clinically, 4 stages are seen. So, the first stage is seen at birth or shortly after birth. The baby is presented with erythema and bulla formed in a line. After 2 months, varicose lesions are developed. After this stage, the lesional area develops pigmentation, irregular pigmentation, which persists for months together, and thereafter they disappear automatically. And the first stage, atrophic linear lesions, are mainly seen in adult females. The microscopy features of first stage include spongiosis, intraepidermal vesicle formation, and the vesicles filled with eosinophils and dyskeratotic cells, and dermal infiltration of many eosinophils and lymphocytes. In second stage, the varicose lesions shows acanthosis, irregular papillomatosis, hyperkeratosis, intraepidermal keratinization and dyskeratosis, basal cell vacuolization, and decreased melanin in the basal layer. In third stage, the melanin incontinence is very prominent, superficial scarring, and depigmentation of the basal layer is seen. These are the pictures of Incontinentia pigmenti. These are the clinical pictures showing bullous lesions and pigmentations. And this is the microscopy picture showing diffuse infiltration of lymphocytes and eosinophils. Hypomelanosis of Feto. Previously it was known as Incontinentia pigmenti acromians, which was a misnomer because pigment incontinence is not seen in this condition. This condition is associated with mental retardation and seizure disorder. Clinically, this is presented as hypopigmented streaks This is the clinical photo, and the hypopigmented area shows decrease in melanin granules in the basal layer. Fewer or smaller melanocytes are present in the hypopigmented areas. The microscopic picture of this lesion, which shows nearly no abnormality, but in immunohistochemistry stain with melan A, the lesional area shows absence of melanocytes, while the surrounding normal area shows normal number of melanocytes. And with this congenital condition of the skin, I finish my presentation. What I presented here is like a drop of water from the ocean. I hope it will be a help in understanding genodermatosis. These are my references. I would like to thank Dr. Biswanath Behra, Additional Professor Dermatology, AIIMS Bhubaneswar, for providing me clinical photos. And the last but not the least, I would like to thank Dr. Nadeem for creating this platform and giving me this opportunity. Thank you.